have launched into our afternoon, which is our final segment today, talking about federal health policy and its potential impact on states, including the state of New Hampshire. And a conversation about federal health policy would not have any integrity without our next speaker, who we are so privileged to have with us, Cindy Mann. She is a partner at Manatt Health and is integrally involved in assisting a number of states in transformation. She is a Medicaid policy expert in so many ways. She's a vast resource for information and has the ability to not only help transform and advise, but to give us a broad swath of information about what's going on so that we can then follow up in her footsteps. She worked at CMS for many years as the Deputy Administrator of CMCS and also a Director at the Centers for Medicare and Medicaid Services, where she worked directly with our region and was instrumental in many conversations about Dear New Hampshire. She has roots in New Hampshire, so those conversations were much easier, at least more open and honest than they may have been with other CMS administrators, and for that we were always truly grateful. And then prior to that, she worked at Georgetown University Health Policy Institute, Georgetown, my legal alma mater, and she was the founder of the Center for Children and Families there. So she has vast experience, and we are so proud to have her back talking with us about health policy. She's going to speak for a while, and then our own Deb Fournier is going to come back up, and the two of them, moderated by Yvonne Goldsberry, are going to answer some questions and field some of your questions about federal health policy. So, Cindy, thank you so much.
Great to be here. We're all still together, right? Waiting for the happy part of the program. This has just been such an amazing meeting. I, of course, resisted when Lucy said come to the symposium only because it's a little busy time in D.C. And I find myself in this room, partly because Lucy's so wonderful and insistent, but enthralled by the discussion. And it's just rich, and learned a ton, took a bunch of notes. So I appreciate everything that everybody here, the speakers, but also all of you in the audience through your questions and certainly through your work have done to contribute to not only a great conversation today, but also for all the gains that have been made in the New Hampshire Medicaid program over the last period of time. So where's the slide? I was struck when I was looking at the cover to the slide that the conference is called Medicaid Tomorrow, and here I am talking about federal policy developments. So we're not going to say, I will follow in Senator Hansen's words, that it is tomorrow. This is not necessarily tomorrow. This is what is under discussion in our nation's capital and really around the country in forums like this. And it is not a done deal, but this bill has passed the House of Representatives, and it is under serious consideration in the Senate as we speak, with a goal, their stated goal, to potentially finish up by sometime this summer, maybe before the July recess. More realistically, I think if they're going to get a bill through, to try and do it by the August recess. But these are uncertain times, and so we shouldn't assume anything, but we also should, I think, take the senator's advice, and however we feel about the bill, get engaged, as well as think about next steps going forward. So I'm going to try and explain a little bit about some of what's actually in the House bill, and let you know a little bit about areas where we're hearing, anyway, the Senate may diverge, but we really haven't even seen a draft yet, even at the staff level of a Senate bill. So there's lots of discussion about whether it's going to be 80%, I think Senator Cornyn said yesterday, like the House bill, or whether they're starting all over again. So it's probably closer to the 80%, I would say, but that's really where they'll start off, and then there'll be a lot of discussion with a lot of senators, hopefully weighing in on what's important to them. So I don't think I need to spend a lot of time on Medicaid today. because we've certainly had a robust discussion about it. But you know how important Medicaid is to New Hampshire and the significant amount of dollars that is spent on the Medicaid program, but also received by the Medicaid program because of the federal-state financing arrangement. We know some of the basics, which is that the match rate is 50% for the regular match rate population, 100% in 2016, which is the year of this data, for the expansion population, 95% this year. And as Deb Fournier explained, that is the match rate varies by state depending upon their relative per capita income. So our friends in Maine have a match rate of 64.38% instead of the 50%. Massachusetts is with New Hampshire on the 50%, and Vermont is at 54.46%. So, and as we know, let me just go back here for a minute. Who was having trouble with these arrows? And I was like, oh, those are so simple. What's the problem? And I think the senator said it as well as anybody could, which is just it's an incredibly diverse population. And so one of the big takeaways is that about what's going on in Washington is it's really not about the ACA, is it? If it's really about the ACA, about the Affordable Care Act, whether it's fixing it or whether it's repealing it, one would wonder why we're in the situation where pregnant women and children and parents and people with disabilities and seniors and Medicare beneficiaries and people receiving family planning services and people eligible because they have breast and cervical cancer are part of this discussion, because the Affordable Care Act's intersection with the Medicaid program really was with respect to simplifying the application, blending it in with the marketplace, and providing the opportunity for states to expand coverage for certain adults. But the changes that are under discussion and the changes that are in the House bill are not limited to that population, and do not underestimate the lack of information about that basic fact. And it's exemplified by a conversation I just had with somebody who came from a meeting with a House member in a committee of jurisdiction, right? So not a random House member, from a state that did not expand Medicaid. And the individual from a hospital system in that state brought to that representative some data showing what the per capita cap might mean in that state. And he expressed great surprise and said, well, I don't understand. We shouldn't have any cuts in our state because we didn't do Obamacare. So the idea that people don't, not just the public, right, but decision makers don't understand this is long-term care, this is home and community-based services, this is care for kids with who are in foster care, this is care for the healthy kids that, as Deb has pointed out, is the bulk of the program. This sweeps in almost every aspect of the Medicaid program in one way or another. So let me just go through the basics on financing, which Deb did note. Since the inception of the Medicaid program, since 1965, the deal has been that to states, you don't have to go into the Medicaid program. If you do and you follow the minimum requirements, the federal government will share all costs. That is the deal. You, the state, need to enroll all eligible, anyone who knocks at your door who's eligible, and serve them. You can't have a waiting list. You can't say, I'm sorry, you can only be helped on Tuesdays. You can't have lifetime limits. You've got to follow the rules. But when you cover an eligible Medicaid beneficiary and provide them with a Medicaid service, then the federal government will share that cost. And the share of the cost is determined by the match rate that we just talked about. That has been the fundamental deal since the program was established. That is the deal that is abrogated in the House bill by saying, yes, you'll still have a match rate, but when your cost hit a certain amount of dollars preset in the bill, then you won't get any more. Then the match rate is essentially zero, right? So you'll get your match rate, but up to a certain amount of dollars, and above that, the federal government will no longer contribute. So I'm going to go through that. But that is the basic construct of financing that is being changed, again, not just for the so-called expansion population, but virtually for virtually every aspect of the program. So I'm not going to go through the delivery system. Deb's presentation gave us lots of great data on where we stand in terms of enrollment in standard Medicaid and in terms of the New Hampshire Health Protection Program. And you see some beginning to drop off in standard Medicaid, not leveling off, but certainly the rate of growth in the expansion has been modulated. And we do find in lots of states that some people who would have gone into standard Medicaid are now going into the expansion because of they're eligible based on income. They might have been eligible before based on disability. They might have been eligible before based on pregnancy. And so that's perfectly legal, let me just tell you, having worked on the rules on that. The idea is people can be eligible based on income, not based on different categories. So that's why you see a little of that phenomenon of the standard potentially going down a bit. Other states have seen that as the expansion gets phased in. So we've also seen other positive effects of having more people be covered. And it was not surprising. People predicted likely we'd see the uninsured rate go down, and likely we'd see the uncompensated care rate go down. And we have seen this in state after state that has collected data, that the state of the hospitals, the hospital associations, that uncompensated care has gone down, and talk about squeezing out some waste in the system, right? It makes a lot of sense not to have care that's provided that no one is payer for because those payments get either absorbed or shifted elsewhere, whatever. It's not going to be in the sensible, never mind value-based kind of way that we're all seeking to achieve. We have seen certainly a drop in emergency room visits overall, actually, but significantly a drop in the uninsured emergency room visits. And we've also seen in New Hampshire the municipalities saying that they too have saved dollars in terms of some of the services that they were providing now being covered by the Medicaid program. There is no question that Medicaid is a big program. There's no surprise to us as to why people, whether it's at the state capital or whether it's in the Capitol in D.C., pay a lot of attention to Medicaid. It is a big program. It is now the single largest source of health care coverage in the nation. But I want to dissect a little bit in terms of the state budget issue, because it gets sometimes blurred when the numbers get mushed together. That's a technical term. Oftentimes what we see is Medicaid as a share of the state budget, looking at the federal and the state together, the federal and the state dollars together. And then it seems to consume the entire state budget. But when you're looking at how much Medicaid affects other priorities of state spending, it makes sense to look at state funds in Medicaid as a share of overall state spending in the state budget. And for that, it is not small. It is 19% of your state budget. But it's important to look at state-only dollars. It's significantly higher when you count in the federal dollars. And when we're talking about what's going to go on in terms of federal financial participation in the Medicaid program, should the House bill or something like it be enacted, this is what's at risk in terms of large dollars. Is Medicaid is the largest source of federal dollars coming into the state of New Hampshire. It is 48% of all the federal funds New Hampshire receives from all sources. So that it is a impact on individuals, it is an impact on families, it is an impact on healthcare providers, health plans, and it is a very big impact on state budgets as well. So I'm going to walk through the provisions of the American Health Care Act, which is the name of the House bill. And many of you may be very familiar with this, and some of you may have been doing your day jobs and not have spent as much time looking at it. Basically, the two big changes relate, as the Senator talked about, the expansion and the per capita cap. So let me start with Medicaid financing. The way the House bill would work is there would be what's called a per enrollee or per capita cap that builds up to an aggregate cap. So the bill provides that the amount that a state spends in a particular year, and I'm going to go through the base year question, for the elderly, per individual, per elderly individual, for children, per child, for people with disabilities, per person with disabilities, will be calculated. They'll come up with a number. And then that number will be trended forward using a national trend rate, and that will be the amount of dollars that you, the state, can draw down from the federal government in perpetuity until they change it. So instead of that arrangement where if you have an opioid crisis and more people need health care service, or whether you have new treatment for Hep C and more drug costs, or whether, and you've all talked about this during the day, you've got a workforce crisis, right? And you may need to up rates of payment and salaries for home care workers or nurses or nursing home workers, all of were mentioned today. Those additional costs either have to fit into the cap or are borne fully by state dollars. And that is the fundamental difference. Right now, if you decide you need to raise salaries or raise rates, because that's the way you can assure good access and good quality, the federal government will put in its 50 cents on the dollar if it's the standard program, or 95 cents on the dollar if it's the expansion program. But the bill would cap it, and when I say it builds to an aggregate cap, here's how it would work. They'd figure out the cap for each of the per enrollee groups, the per enrollee caps. So you have a dollar for the kids and a dollar for the people with disabilities. And then in any given year, they would calculate how many people you enrolled in each of those categories and then add it together, and that would be your aggregate cap. And so at the end of the day, if you ended up spending less per enrollee for kids but more for the elderly, or less for the elderly and more for the kids, federal government doesn't care about that. They're going to compute an aggregate cap, and they're going to say, just don't spend more than this total amount. And that has implications, too, that it's not a cap that binds per eligibility group, but it is an aggregate cap that's built up per eligibility group. So one of the things that's really important that we're going to talk about is how that base is figured out, what's in, what's out. And one of the things that's really important that we're going to talk about is what's that trend rate. What does it mean after they've established the cap and it's adjusted year by year with a trend rate? What's the implications of that? So that's the per capita cap towards the end of the very short, really, if you think about it, time that the House was debating this bill. They added a block grant option. And a block grant option would work a little bit differently. And it's an option for states. You could cover non-disabled, non-expansion adults, which is really pregnant women and very low-income parents, and children in the block grant. And the trend rate would be even less favorable than for the per capita cap. And the amount of state dollars that you could pull out of the system would be greater under the block grant. So there's a little financial carrot and a stick in terms of doing the block grant option that we can talk a little bit about more if people have questions about it. We've heard about the expansion. The expansion is generally, the rule is much easier to explain. In the House bill, the bill would not allow any new state to come in and do an expansion. And for states that have done an expansion, they would end the enhanced match rate that you get, which would, by 2020, would be at 90%. So instead of 90% in 2020, it would go back to 50%, your regular match rate. And except for what's called grandfathered individuals, except for people that you had enrolled as of December 2019, and that stayed enrolled without a break in coverage for at least 30 days. And I'm mindful of that graph that Deb showed us about how quickly people leave the program for any number of reasons. And that's very consistent with the research that we've done and, frankly, with CBO's projection, Congressional Budget Office's projection. So for all intents and purposes, within about 2.5 years, almost all your grandfathered individuals would be gone. Some would stay on, but a small number, and I've got some data for you to share on that. The last thing that I'll just mention is that there are disproportionate share hospital cuts. We had a conversation about it last night. It might not have such a big effect in New Hampshire since you aren't drawing down all your DSH dollars. But those cuts for expansion states would go into effect in this year, October of 2017, for the expansion states, and would be not go into effect for non-expansion states, trying to balance out the benefits that expansion states have gotten that the non-expansion states have objected to that they didn't get. And by 2020, they go away for everybody, as does the expansion match. So this table really gives you some fundamental, it's not really a description of the American Health Care Act in and of itself, but it is the general step back. What does it mean to have a cap on funding versus the kind of financing that we have today? All of you, most of you are working in the field, and you don't spend a lot of time thinking about the federal-state financial arrangements that go on. But this really shows the difference in a block grant versus a per capita cap. Fundamentally, the difference of a per capita cap versus a block grant, both of them cap the amount of federal dollars that you get, but a per capita cap does fluctuate based on the number of people that you serve. So if you enroll more people, you will get another per capita cap payment, essentially, added into your aggregate cap. Whereas a block grant that I said is an option for the kids and some of the non-disabled adults, a block grant is a set amount of dollars. Both of them in the bill would grow a little bit over time, but the block grant does not vary based on how many people you enroll, and the per capita cap does. Both of them, however, shift risk to the states, and then to providers, and then to families and communities. The block grant shifts the risk of both higher enrollment and higher health care costs, higher than the caps, right? And the per capita cap, it is said, although we're doing some modeling that suggests otherwise, that states bear the risk only of the higher health care costs, but not higher enrollment. Let me just say a word about the higher enrollment without hopefully losing you too much in the math. You can imagine that at some point, outlier people, otherwise known as our neighbors, right, who have high health care needs, are going to be, some people are going to be more costly than others in the state Medicaid program. They are now, they will be under a cap. And so there is a point in time when a state may decide under a per capita cap, well, that's fine, I get an extra payment if I cover that person. But that person is so expensive, I'm better off not covering them at all, because they're an outlier relative to the cap. And I am better off making sure that I don't cover that individual. And so the whole notion of pre-existing conditions and the whole notion of selection, which has really never been a feature of the Medicaid program, suddenly begins to figure into the financing potentially. So I don't think enrollment is completely protected. You do get a new payment for every person covered, but there may be the math involved that says to you, I'm not sure that's a good deal for me. Let me talk a minute, because I'm not going to say a lot about state flexibility, but there's this theory that you get a lot more state flexibility if you cap, that's the trade-off. Okay, cap my funding, because that doesn't sound really like a good idea. Why would governors say that's a good idea? Cap my funding, but in exchange you will give me more flexibility. And that is often the discussion. That is not the reality of the American with Health Care Act. I mean, one would argue if you have less money, flexibility may not get you very far. But partly because the bill is going through a reconciliation procedure, which is the procedure that allows them to get it through the Senate without risk of a filibuster and only needs 51 votes. They can only include certain things in the bill that has a direct budget impact. So if you put the whole program under caps and then you fiddle with the flexibility under that cap, everybody's suspicion is that the parliamentarian will say, those provisions don't belong in a reconciliation bill. And so even in the House bill, in anticipation of the Senate rules, the only new flexibility in the bill for the standard Medicaid, well, for all the Medicaid program under the per capita cap is the option to do a work requirement. If you choose the block grant option, and I'm not sure it's fully intended this way, but certainly the way I read the law, if you do the block grant option, there's a tremendous amount of flexibility. Rules around EPSDT, federal guarantees for benefit packages for children disappear. Lots of different rules under Title 19 that governs the Medicaid program seems to disappear in the way that they've designed it. But the basic program under a per capita cap does not include the promise of flexibility, although certainly the administration has made it clear that they're willing to entertain waivers to that effect. So let's get into some of the considerations, and I'm going to touch upon each of these factors. These are sort of the components when you think about the proposal that you're going to want to think about, because as you see different iterations, right? I'm going to talk about the Americans for Healthcare Act, which is the House bill. We'll presumably see some different iterations coming out of the Senate. You're going to want to look at, is there first of all, you're going to look at, is there still a cap? Is there still an elimination of the expansion? And if there is a cap, what's the base funding? What is it based on? What happens to the trend rate? What trend rate are they using? What happens to the state spending under the new financing arrangement? How are supplemental payments and waivers treated? And what, if any, new flexibility do I get? So this is my big proviso as you look at this. Anybody, apparently, as Joe would attest, who shows any Medicaid data has to start with a bunch of caveats. Okay, so this is my caveat. This is 2011 data. Okay, so we have all been, you've been actually doing it. I've been watching you do it over the last 10 years or so, making major changes in the Medicaid program, and so I well know that 2011 does not represent where you are right now. But that is part of the point, which is it is the most recent year for which there are 50 state data reported to CMS by states. And so I'm going to show it to you, not because it'll be your cap, but because it is somewhat indicative, at least of where you stood in 2011, and it may change a little bit. But it also gives you a sense of the problem with the data in the base year, right? What the bill provides, and this is enormously confusing, so let me try and say it in a simple way. The bill says we're going to look at 2016 spending in the state to set up the cap. But the bill writers knew, having talked to somebody in the know, that they don't have the data at the federal level right now that would allow them to compute a per capita cap for each state, right? Deb didn't present it today. She doesn't have that data. Neither do the feds, neither does the Congress. So then they say in the bill, we're going to actually figure out the caps themselves based on 2019 data, and you all have fair warning, you better get your data in there, is sort of what the bill says, and has some penalties if states don't get their data in. But they don't want states to game the system and start beefing up their spending so that 2019 looks very robust. So they start again with 2016 as the break, right? So if they'll figure out your per capita caps in 2019, but if those caps overall, if the overall is more than what it would have been if you just had grown your 2016 at the CPI medical rate, which is low, then they will ratchet down your caps in 2019. Okay, so it's 2019 caps, but bounded by 2016 spending, is how it works, simply stated. So where were you in 2011, for which we had overall data? You were about 12th overall, but that doesn't necessarily tell you a whole lot. You had higher spending than most states. When you looked at elderly, children, and people with disabilities, you had significantly lower per enrollee spending on adults. And the bottom line, though, is not so much, is this the dollars that you are now? It's not, no doubt it is not. It's a very different world. But the point is all the things we've been talking about and all the things that you just did since 2011, right? If you fast forward that and say, let's imagine these were your caps, and we were in a capped environment starting in 2011, all the things that you might have done to increase some of your provider rates, to change some of the way that you were spending your dollars, to beef up some of your mental health, substance use disorder services, those would have been based on that historic spending with the cap, with the trend rate adjusted. And so the point of a cap is it freezes a state wherever it was in that base year, modified only by the trend rate. Maybe that was a great year for you, and maybe it was a terrible year for you. But whether it was great or it was terrible, it's probably not going to be the same experience you have 5 years later, 7 years later, or 10 years later. And that's the ultimate issue, I think, as states think about what the implications of cap funding are. So I mentioned we also need to look at supplemental payments and waiver payments. So the base is figured out by your per enrollee spending in that base year, the 2016, 2019 hybrid. And then they'll think about, it was a big question. There's a lot of states that rely on supplemental payments, non-dish supplemental payments and fee-for-service. New Hampshire doesn't rely that much on it. You've got a little bit, looks like about $6 million of that. DISH is outside of the caps. DISH is one of the few things that are outside of the caps. DISH and the payments for premiums and cost sharing for dual eligibles. It's pretty much all that's out of the cap. Other dual services like long-term care is inside the cap. So it's not that duals are outside the cap. It's just the premium and cost-sharing payments you make for the Medicare that Medicaid makes on behalf of Medicare beneficiaries for their cost-sharing obligations. But you did just get a DSRIP waiver. And so one of the things we looked at is what happens with your DSRIP waiver payments. The way the bill in the House is written is they'll take into account if you had any waiver payments in the magic base year of 2016. Well, you had one payment, as far as I could tell. You had $19.5 million in that magic year, and all your other money is going to be over the period of time not in that magic year. So the proportion of, there's a formula that they'll take into account the 19.5. It's not dollar for dollar, but it's a formula. What that means is that your $30 million payment in 2020 will be subject to the cap, but it will not have been built into the cap. So you'll already be over the cap in 2020 unless your spending goes down for your other populations. It doesn't mean you can't get that waiver payment. It means if you want to retain that waiver payment, you would have to make room under your cap for that waiver payment. And that's small, that's $30 million, okay? But it gives you it's very big in terms of your planning, but it gives you a sense of how a cap works. Sure, you could get some extra money, or sure, you could spend some other dollars, but it is a zero-sum game unless the state, are willing to sustain it with state-only dollars. So let's look at the trend rates. In the bill, they use 3 trend rates. And if you do the block grant, I said it was the least favorable trend rate. They will trend the block grant dollars, your 2016, 2019 magical base, by the growth in the consumer price index, which CBO projects over the next period of time will be about 2.4% growth. In the per capita cap world, which is virtually everybody except for, well, it's virtually everybody because it does include duals. For the elderly and the disabled populations, it'll grow at the medical CPI rate +1, which CBO projects. We don't know what it'll be, but CBO says, I think it'll be 4.7. And for the rest of the population, your kids and your non-disabled adults, it'll be at medical CPI, which is 3.7%. And so you take your base rate, that base year, and every year it grows by these amounts depending upon which group we're talking about and adds up to the aggregate cap. Okay, you with me? Okay, let's talk about these trend rates. First of all, they're national trend rates. They're not state trend rates, right? Different things for different states, but the goal here is to reduce the federal dollars and to make the federal dollars predictable. And they have intentionally, and this is not, I'm not trying to be nefarious here, they have picked a trend rate that they know is below projected Medicaid spending because that is one way to get the savings, and they are explicitly looking at reducing federal spending in the Medicaid program. So they expected it to produce savings, and that was part of the goal is to reduce federal expenditures. So first of all, medical CPI. I do a lot of stuff on Medicaid and healthcare, right? How many people here have really studied and think about medical CPI? There's no such thing as medical CPI, as it turns out. I kept Googling, what is medical CPI? Turns out there's some medical items that are components of the consumer price index. And that is now pulled out. Those components are pulled out, and they're called medical CPI. So what that is consumer out-of-pocket spending. Now, talk about something that is a mismatch to Medicaid spending for kids and people with disabilities and long-term care. This measures, out-of-pocket spending by consumers, the Consumer Price Index for medical care. Could be deductibles, could be, drugs or other services not covered by your insurance. That's what medical CPI measures. Okay. Not only is it a mismatch, but you won't know what it is you won't know what it is when you're even in the year you're spending, never mind in the year that you're budgeting for the program. Medical CPI comes out month by month, and there's a month lag. So when you set your budget, a year before, 6 months before, 2 years before, you're going to be guessing. And you're going to guess, and Deb can correct me, but I would bet my year's salary, I think that most Medicaid directors are going to bet low. Because what happens is if you go over, you get what's called a clawback the next year, and your cap is reduced by the amount that you went over. Well, nobody's going to want to sit in front of the budget committee and saying, I overspent, and guess what? Now we're even worse off the next year because we get a further reduction in our cap. And it is notoriously unpredictable. So even though I say CBO had this projection, it's going to be 3.7, it's 4.2 and 3.7 and 2.4, this is the graph that shows you what it's been over the last decade or so. It goes up, it goes down. So it matters which trend rate you pick, but it also matters where it lands, and it is inherently unpredictable. And that's what you will be managing to. So this is a little bit of a teaser, and I understand that. We are working on a model that looks at state-by-state impacts on per capita caps. And we're doing that. We did this to show what the difference in New Hampshire. This looks at if the medical CPI is 3.7 over there on your left. If it turns out to be 3.7, and therefore medical CPI plus 1 is 4.7, right? So we're following the rules of the bill. In 2026, under different assumptions, and we can get into what they are, that 1 year you would have to have a cut. You would be have to bring your spending $231.6 million below what it would otherwise be projected to be. Now, whether my projections are right, I mean, I'm using different projections or not, is anyone's guess, but those are, actually, that's not a secret. I'm using the Office of the Actuary projections of Medicaid costs. But if they're wrong, so that's not a small cut, right? And I'm not talking the expansion yet. Stay tuned for that. But if the medical CPI is 3.2, it goes to $365.2 million reduction. So what that trend rate is matters quite a bit. Either way, you have abrogated the fundamental handshake between the states and the feds that will share in all costs, but obviously the trend rate matters quite a bit. So I mentioned I'd give you a little bit of a teaser of things that we're hearing about the Senate. The Senate seems, when I say the Senate, I really mean the leadership in the Senate, because I think a lot of senators have really not weighed in yet on any particular proposal or whether they'll go along with the proposal. But they are pretty committed to a per capita cap, and what they're thinking about is what we hear is 2016 the right base year or not, and what's the right trend rate. And of course, like everything else in Congress and probably in most state capitals, there's a group of senators that want it to be a more generous trend rate, and there's a group of senators that say it's too generous a trend rate, looking at what the House did. So those are some of the factors, those are some of the elements that are very much in discussion. So when I think about what is some of the considerations for New Hampshire, it is hard to avoid the issue of your graying population. And I say that with great admiration and affinity. Your population is getting older. Now, if you were getting older exactly in the same proportion, age-wise, as you are now, that would be okay, right? Or you would be, okay, I've got to live within this cap. The cap was set in 2016 or 2019, depending upon which way you look at it. And if the distribution of your elderly was exactly the same as in your base year, you know what you're dealing with. But what's happening in New Hampshire and in some other states is that not only are you having more people over 65, but more of the people over 65 are over 75 or over 85. And they are, not surprisingly, more expensive. And so this gives you some data based on census projections that in you'll see the data in 2015 versus 2035. You really switched in terms of the majority of people elderly being between 65 and 74 versus the majority of your elderly in 2035 being over 75. So that will make your cap that's set years earlier even more out of date because the demographics and the acuity of your elderly population are going to change. You also have some particular issues with the way you finance and the way you provide long-term care. And you have county responsibilities for both the provision of nursing home care and for some of the payment towards nursing home care. And you also have the demographic impacts in terms of the aging of the population are experienced differently across the state. And so, as is often the case, you know, states get cost shifted, and maybe the counties will then bear some additional costs, and it will not be equalized across counties. So it's going to be another consideration that you and your partners in the counties will need to think about. So here are some step back considerations, and the first one goes to the issue of what happens to the state dollars. So the talk on per capita caps or block grants is that it fundamentally, and it's not a this is a matter of math, right? It does shift costs onto states, right? Costs that were borne by the shared by the federal government and the states would now be borne by the states alone if those costs exceed the caps. So the question for any state, including New Hampshire, will be: will I spend that extra dollar? Will I, if I have costs that exceed the cap, will I take money out of the state treasury and knowing that I'm not going to get a federal match for it and spend that money because, in fact, that's what my costs are? So that's a key question. And you can, you know, different states may act on that in different ways and at different points of time, right? We all know that states sometimes are in recession or in economic difficulty and may want to do that and not do that because of those constraints. Many states have actual state laws that say we will not spend any dollar in our Medicaid program unless it can be matched by the federal government. So you'll have to think about that. But let's imagine New Hampshire says, I'm going to do what I can do to draw down the most amount of federal dollars I get and no more. Okay? That's not an atypical reaction. Let's imagine New Hampshire has that reaction. And the federal dollars are cut. So what that means is that the state dollars, the state contributions are reduced as well. So if the state only spends that which is necessary to bring down all the federal dollars that are available and the federal dollars are going down, then so too will the state dollars go down. Now the state may say, well, that's a great deal, but in terms of the funding for the program, it's an additional reduction in overall funding. Again, it's a behavioral question. I don't know what the answer is for any state, never mind New Hampshire, but those are the considerations we'll need to think about. Cost pressures, we're going to have cost pressures. Now maybe you guys can just really go forward and figure out all the value-based purchasing and bring down your costs and your integration of behavioral health, and that's obviously the important direction that we're all going. But by and large, states generally control their Medicaid costs by looking at enrollment, benefits, and provider rates. Those are the three big levers. So what will happen in terms of the reaction to any reduction in overall spending, both federal and potentially state reductions in spending? And we're also going to see greater competition. It is a zero-sum game in some respects, right? So there's always competition in terms of do you add people to the waiting list, drop a waiting list in terms of a home and community-based waiver, or you add payments over here. Life is always about priorities, but it becomes even more difficult when when the federal government is not joining in sharing the costs. So let me touch on the expansion, and simpler to explain so I can go through it faster. As I mentioned, what the bill would do is end the funding for end the enhanced match for the expansion population effective 2020. And so we've mapped out, and I think it's very consistent with what we've seen in terms of your data so far, and it's consistent with other states that have phased grandfathered programs that you sort of look at the attrition over time. You see that most of the people end up losing coverage as a grandfathered individual because they've had a break in service for and coverage for more than 30 days. You see the big drop really by year 3 and 4. And then it drops more gradually after that period of time. And so it appears that most of and this is true not just for New Hampshire, that if the state decides, and it would be a state choice, to only cover the grandfathered individuals. So the state could say, I'm going to keep the full expansion going, and I'll pay the regular match for anyone who's not considered a grandfathered individual. That would obviously be an additional state contribution to make up for the loss of the match rate. Or the state could say, under the House bill, I'm only going to cover the grandfathered individual. So if the state only covers the grandfathered individuals, here's what your loss in coverage will look like over a 5-year period, 2020 to 2026. And this is a little bit confusing chart, but let me try and explain. There's 2 options, as I discussed. If the state maintains the adult coverage, New Hampshire would need to spend, by our calculations, about $345 million in state funds in 1 year, in 2026, to make up for the reduction of the federal funds. And it would be losing $345 million, right? So it loses $345 in federal, and if it's going to maintain the funding, it would have to maintain the expansion. It would have to put in that amount of dollars. And if it decided, I'm not going to maintain the expansion, I'll just keep the grandfathered individuals for as long as they stay on and keep getting the enhanced match until those grandfathered people disappear, then New Hampshire wouldn't be spending additional state dollars, but would be losing a total of $594 million in the year 2026. So, and this is separate from the per capita caps. This is just looking at the impact of the expansion. So I talked about flexibility, and I think it's really important to weigh that. I think the administration is very serious about being willing to entertain new flexibility. Hard to know whether it entails spending more or other programmatic changes that may bring down your spending. But you can get that flexibility without a cap funding. But as you think about going forward, you might want to think about different flexibility. But you can, if the idea is to make the program more flexible, then we could have a debate about whether that should also has to come with the price of having cap funding. But as I mentioned, there's no new flexibility in the bill itself other than the option to do a work requirement, and except for the block grant, which does provide significant new flexibility. And states could ask, there's nothing in the bill that says waivers are no longer allowed. States absolutely could ask for waivers under the provisions in the House bill, but it's all subject to the cap. So if you ask for waivers for more money, you're going to have that zero-sum game that we talked about. If you ask for a waiver that would allow you to do other programmatic changes, then that may increase your ability to reduce your spending, and that would be permitted. Either would be permitted. One, you have a little bit of a tension. So I thought of, like, is there a good story to tell at the end, or a comic strip or something? I couldn't come up with any. It's not my forte. But I will say that 2 things. One is it's a resilient group of people, and it's a resilient program. There's been lots of times when I think people declared the demise of the Medicaid program, and it jumped together, and it jumped up and took hold, whether it was to help with infant mortality or to solve the AIDS, not solve, but really help in terms of HIV/AIDS, or providing the funding for providing long-term care services in the home instead of in institutions. It's really done a lot of amazing things, obviously, by the people that make it happen, which is all of you in the room. So I have no doubt that if caps come along, and there'll be a lot of good thinking that goes on. But I would agree with what the senator said, which is that don't assume it's going to happen. And if you're inclined to state your opinion one way or the other, this would be the time to do that. So I think we're going to have discussion.